You really, sorry about that. So it's just a different, you know what, we can improve these areas. One of them is we want a smooth, steady slope, meaning the lip from side to side doesn't just drop off. Now, this is iatrogenic, meaning if you see someone in nature and they have a lip that's peaked in the middle and drops off on the sides, it might be completely beautiful. It can be the most beautiful thing ever. There's an actress, I forget her name, but she's in the TV show The Queen's Gambit, and she's very popular now with big giant eyes and has this lip that comes and drops off on the side, and it's a beautiful lip. However, if you're operating on somebody and you're altering them, and the mouth already has a tendency to drop off more on the side with age, then it really helps to try to keep the lip smooth and steady as it goes off and not drop off on the sides. The other thing to look at is the internal portion of the lip, which we call the mucocutaneous junction or the wet-dry border. And this is called the internal arc of the lip, which is this part of the lip on the inside under your vermilion. This on most people looks nicer if it's smooth, if it's a smooth arc, just like the McDonald's arc. What you don't want is an M shape. M shapes look a little more angry. Indents on one side look a little strange. They look a little clefty. You don't want it pulling on one side. That's a snarl. It makes you look like Sylvester Stallone. So there's all these different things that change the character and how people perceive you. So you want to be perceived as a nice person. Unless you want to do cage fighting and you want to scare people, then you can do the Sylvester Stallone thing. Naturally, you can have anywhere from 0 millimeters to 8 millimeters of tooth show, and it looks fine. Iatrogenically, when you're changing somebody, you really have to look at the balance and closure of the mouth. If you go over 4 millimeters of tooth show in somebody who didn't have it before, they're likely going to have problems closing their mouths. And there's no definitive on what's good for tooth show. It's looking at the patient, looking at their teeth, looking at the position, and you say, you know what? This person would look good with some tooth show, because tooth show might make you look younger, might make you look brighter. If you have ugly teeth, and this is not a joke, if you have ugly teeth, you don't want to reveal the teeth with a lip lift. It looks terrible. They look harsher, they look uglier. It's not a nice thing unless the patient's willing to fix the teeth. So you do have to consider these things and realize again that there's functional implication, meaning if you show too much teeth, the mouth can't close, and whether you understand the dynamic or not, this is something that can accelerate aging. If you have poor mouth closure, which this happens very often, especially with dentists right now, they're making big, giant teeth. What you do is you accelerate aging of the neck. And this happens because the mouth, when you look at the upper portion and the lower portion of the mouth, meaning the maxilla and the mandible come together. However, the upper lip is hanging, and it doesn't have any real true depressor function. The only depressor function you have is a little bit of squeezing on the vermilion, which isn't real depressor function, and you have the DAOs that are pulling the mouth down. And when somebody has difficulty with gravity closing their mouth, their lips together, then what happens is the lower lip and the chin become hyperactive, and people start pushing up like this as they close their mouths 1,000 times a day. And when you do that, the depressor function of the corner of the mouth tries to pull the upper lip down, the chin goes up, and you end up getting a deepened sulcus mentalis. Your chin goes up over time, and from the side, the digastrics are fighting it, and you end up seeing this slope of a neck, which is actually very common to see in people with prominent upper teeth. So you do see that where they get this early slope neck, and this is neck aging that happens from teeth being in the wrong position or poor mouth closure. So you have to realize that strain on the face causes a lot of issues with aging and a lot of issues with how we're perceived by other people. So you do have to be in tune with tooth function, tooth and mouth closure function, just as if you're doing eye surgery, you have to be aware of the eyeball. You can't just do eye surgery. And you want to be nice and balanced in the Cupid's bow. The Cupid's bow itself can be blunted like this. It can be sharp like this. You want something in the middle, usually, that just parallels your columella. As far as ratios go, you'll read about the proper lip height and the proper chin height and the proper ratios. And even for chin implantation, this is a whole nother topic I can talk about. These are guidelines. They are not definitive, and most of them are incorrect. So if you read about how to find the proper chin position on most people's faces via the different the different calculations that we have. I'm sure you guys have learned this. When you look from the side of the face, there are calculations that show that it should go from a plane from the nose to the lip to the chin, or the chin should be a centimeter or 5 millimeters behind the lower lip, or at the level of the lower lip for men. These are really, really improper descriptions and calculations. So if somebody has prominent teeth, that doesn't make any sense. If someone has a big nose, it doesn't make any sense. So you just have to realize that most of these calculations are just meant to be guidelines, just to help you understand how to look at the face, in case you're that 95% of surgeons who doesn't naturally have good taste in these things. So it just helps you develop taste. When we're looking at the ratios of the upper and lower lip, there is no definitive ratio. The only thing that you need to know is people look heavier and they look more simian, like monkeys, if their upper lip is really long and their chin is really short. Otherwise, you just want something balanced, and the size of the lip can be 50-50, it can be 30-50. Just in general, for the weight of the face, you don't want the upper lip being bigger or heavier than the lower lip. The commissure of the mouth, and this is a great example over here, if you look at this patient, is if you look up at the commissure right over here, you can see that it goes upwards slightly, just like that, and then the upper lip sits on top of it. And this is similar to the canthus of the eye, and this is what makes somebody look neutral or happy or sexy around the corner of the mouth. And it's something that we do aim to achieve when doing a lip lift. The other thing I mentioned here is the philtral slope, which if you look right over here from the side, it's the slope of the upper lip. You don't want it to go down, 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 and then come out. You don't want it to be convex. You want a nice little concavity and a jut that comes out like a little ski slope, and that's about it. So these are just concepts of how to look at the lip and try to understand. And here you can see an example of an M-shaped lip that I was talking about, how in the before photo, she looks a little angrier, and in the after photo, she looks a little happier. So there are things that you can change with the shape of the lip to make somebody look more pleasant and happier. Alternatively, there are changes you can make in the teeth to make somebody look nicer and sweeter. In this case, she has very cute, sweet, nice teeth. It makes her look nice. Some people have sharper teeth and it doesn't match their face. Some people have square teeth and it doesn't match their face. So you want everything to just blend harmoniously. Now to the lip lift itself. The Cupid lift, which is what I do, is an amalgamation of mixing a subnasal lip lift with a corner lip lift, becomes this general Cupid lip lift. And if you look at the variety or variations of lip lifts that have been described in the past, they're all over the place. So there are ones that go on the vermilion border, which you should never really do. There are ones that go around the nose. There are ones that go in the nose. What I have found is that the old school one from 1970, which was described by Cardoso and Spurley in a congress, actually not even published, was a classic subnasal lip lift where the incision goes into the nasolabial crease. And that is the smartest one because it separates the subunits of the nose and the lip. And this is really, really important because as surgeons, we try to find the best way to hide a scar, and we look for junctions and rhytids and all these different things. And when doing those things, it's important to remember not to change the anatomy. You don't want to change the subunits of the face or crossover subunits of the face. You don't want to pull the skin of the face onto the ear if you don't need to. You don't want to pull the skin of the lip into the nose and make a lip nose. You don't want to bring the brow and the eye together or make it smaller. These are things you don't want to do over time or with surgery overall. So it's always smarter to keep the subunits separate and distinct, and that keeps people looking more natural. It also allows you the option of fixing things. If you were to take the lip and put it inside the nose and you create one of those lip noses and the patient doesn't like it, or if they consider that a scar, you cannot fix that. If you put high tension on the sill and pull it out and cause these major striations, you also cannot fix that. So it's smart to do surgeries that you can fix, and you can do that by keeping the anatomy as natural as possible. Another misconception is that you can get better or you can get away with a better scar by making smaller incisions. Smaller incisions in this area lead to more tension because you're not able to redistribute the skin all the way across the base of the nose. So putting smaller incisions makes the healing more difficult, more challenging than just putting a broader incision, which could heal better, actually, and you'd see less. So I use a classic subnasal incision that goes all the way across. They call that a gull wing or a bullhorn. People have described the bullhorn different ways, so you have to realize which way they're describing it. But there's double duck, there's all these ones that you see. I like to do it the classic way and prevent issues that way. So the description that I have for the type of procedure, meaning the actual surgical technique, is called the modified upper lip lift or the deep plane upper lip lift. Now, if you really understand the face, you realize that these aren't a deep plane in any way. Deep plane facelifting is not a deep plane. It's just deeper than the superficial plane. So it's actually a middle plane, and it's the exact middle plane of the face. It is the glide plane of the face. And in this case, it is the subsmass plane of the face. And the smass over here on the lip is about 3 to 4 millimeters in thickness. It's a fibrofatty fascial layer, which exists on the face as well. Over here in the midface, it's almost identical to those areas, and it differs in different parts of the face. But this is a plane that we can really take advantage of to help not only take off tension on your closure, but to help preserve mimetic muscle movement. So the muscle movements of the face, you don't want to alter them, you don't want to be pulling on them, and this helps preserve muscle movement and muscle function. There are lip lifts that are done, and they can be 5 millimeter lip lifts, and the person will have 0 millimeters of incisive display, and it decreases their incisive display because they bound up the muscle too tight, and the orbicularis muscle can't squeeze in the right direction anymore because they changed the vectors of it by rolling the muscle onto itself, and now the muscle is confused. So this does happen, and it's an important concept to realize in facelifting, and why deep plane surgery in general is so important. One of the things people don't talk about is that you don't want to alter muscle movement. So that's the benefit, biggest benefit of the deep plane and not looking fake, is that muscle movement on the face can stay the same, whereas when you do more superficial techniques, you're typically causing a negative effect on the muscle layer because you're pulling it when you move the skin. Okay, and most people don't understand that. They think it's actually safer because you're staying away from the muscle. It's worse because you didn't elevate off the muscle, and anytime you pull skin, the muscle goes with it. So that's a big problem that we see in brow lifting. You can see it in face lifting, and you can see it in lip lifting. However, most people don't diagnose it properly. They think it's due to other reasons because they just don't know any better. The lip lift publication I released more recently is the Cupid lift, and the idea of this article is no longer to talk about surgical technique. The surgical technique is very basic, and that's already been described. This is more about understanding the mouth and how it ages and how it lifts and how to avoid all the problems that we see with lifting. And this is the Cupid lift, and it's a way to actually draw out your design on the lip and lift the lip without causing problems using the deep plane technique, which just means we're doing a subsmass technique. The Cupid lift is based on an algorithm that I use to control the ultimate height of the lip along the relaxed skin tension line. So I'm using my relaxed skin tension lines. If you know, like puppeteers, and they have the strings, I'm using them like the strings that a puppeteer would use to help change the shape of the lip, to bring it higher on one side, lower on one side, change the shape of it in a very natural and easy way. Here you can see we have a central line, which is marked C. You have a P line, which is peak, paramedian, philtrum, whichever one you want to call it. You have an intermediate line, and then you have a diagonal line. So CPID, that's where Cupid comes from. There is also the nasolabial fold, which is way out over here, which is your last relaxed skin tension line around the globe of the mouth. And then there's the line in between them that we call the outer line. So if you're aware of these lines, it helps you understand, and you see in the smile that there's a globe which occurs because the mouth is formed over a semicircular structure, which is your teeth and your alveolus. So it forms around it this way, which is why you form this globe that comes around three-dimensionally. And as you go outwards, you'll see that from the central line to the nasolabial fold, it progressively becomes more diagonal and more oblique as you go outwards. If you look closely, you'll also see that in these lines, the pores start to follow the relaxed skin tension line. So the pores of the skin are different from this part to that part but they also start to go outwards more, and that can help you visualize the things that we need to do with the lip. The other thing that you're seeing in this patient when she smiles is that a little bit of the skin tucks up and pushes up against the nasal spine, and there's a little strain there. That would be, if anything, the excess of the lip, if you wanted to remove. So that's one of the ways that you can find it, and we call that the line of declaration. The other thing to try to understand when we're looking at the lip is that the lip, there are many parts to it. So we have the vermilion, the dry vermilion, wet vermilion, vermilion roll, no vermilion roll. We have all these different parts to the lip. And when we're looking at a frontal view of the philtrum, you can actually see that there are two parts to the lip that we need to understand. One of them is there is a subnasal portion, which means there's a portion of the lip which hangs under the nose. And then lateral to that, there's the subfacial portion, which is really hanging from the rest of the face. And there is a big difference between the subnasal and subfacial portion in most people. The subnasal portion is the portion that is that exists between the diagonal lines on each side. Lateral to that, you have the subfacial portion. If you look at the subnasal portion, it's more inverted because it's hanging from the nose. You have a vermilion roll, which is that white roll that you can see right above, which is where it's a fusion plane of the mucosa with the skin, but it's also where the muscles go from pars peripheраlis to pars marginalis of your orbicularis, and the muscles actually right up and touch the mucosa at that area, and they can enhance this roll a tiny bit over there. Laterally, you don't have any more, which means you can make an incision there without effacing this natural white vermilion, and we can take advantage of that. The subfacial lip ages more rapidly than the subnasal because the subnasal lip is held up over time and stays everted, whereas the subfacial lip droops down and weighs down on the mouth over time. This has implications for doing injections with filler as well, because filler can't be used to cause any eversion on the subfacial lip. It'll just hang lower, whereas the subnasal lip, if you put the tiniest bit on the just inferior to the vermilion border, you'll push out and get a little bit of the appearance of a lift or of eversion. It's not actually lifting anything, but it looks like it. So it's important to understand these two things because it'll help you understand how to treat the lip, whether you're doing injections or surgery. The other thing that you should realize about subnasal lip lifting is that it is a subnasal lip lift, meaning everything that we lift is under the nose in the subnasal portion that I just showed you. Lateral to that doesn't get lifted so well. The other thing to realize is that if you look at the relaxed skin tension lines, it's a centrally vectored advancement flap, which means from the middle, when you lift, it goes straight up. From the sides, when you lift, it goes at an inward angle. And if you understand Pythagorean theorem, you will see that for a 5 millimeter lip lift all the way across, the center will lift vertically 5 millimeters. However, on the diagonal portions, it will only come in 4.7 millimeters change in vertical height. So even though you cut away 5 millimeters of skin, the vertical height change is going to be less. So this means that a classic 5 millimeter lip lift on anybody will cause more of a lift in the middle than the side. So you have two reasons that's happening. Number one, because of this vector of advancement, they're not going straight up, they're coming inwards as you go outwards. The other is that the subnasal portion of the lip lift, again, only lifts the subnasum, not the subfacial portion. So those are two reasons why lip lifts tend to pull in the middle more than the sides. And when you look at lip lifts that are done classically, whether they have scarring or not, people look a little strange because of that issue. And this causes problems, again, with mouth closure, not just with appearance. So it has functional implications. So here you see two different faces, and I did a classic subnasal lip lift on both of them. I did not do a corner lift on either of them. I did not do any extra recruiting or anything different on either of them. This is a classic subnasal lip lift. And what you see here on this patient is that this subnasal lip lift, if you look down here, failed. Her lateral lip is buried, especially on the left more than the right. And for me, I would consider that a failure, even though the patient says, no, that's my natural anatomy and I'm fine with it. On this patient over here, you'll see that I did the same exact lip lift. However, it did not fail. She had full exposure all the way from side to side. And for me, that's a success. Now, why is this happening when I did the same surgery on two different people? This is happening because this patient over here has a smaller nose and a wider mouth, meaning she has less subnasal lip, more subfacial lip, and the subfacial lip wasn't lifted. This patient over here has a wider nose that's almost as wide as her mouth, which means that her lip overall with age is not going to lose eversion as much because it's mainly subnasal. And when I do a subnasal lip lift, it lifts all the way to the corner. So this is an example of what I'm talking about with a subnasal and subfacial lip and what a subnasal lip lift affects, which is between the diagonal lines. So you can see why one would be a failure and why one would be a success. So we can use this and actually say, you know what, I'm going to recruit more from the side, which I don't like to do, or I'm going to do a corner lift, which I love to do. Drawing these markings is very straightforward. Now, if you read the article, you can just kind of follow it like a cookbook, which is nice. The upper incision or the upper limb, we call that level 1 of your incisions. There's 3 levels. Level 1, which is the upper limb of your incision. Level 2 is the lower, and level 3 is your vermilion. And this just helps you understand excision heights between level 1 and level 2, and residual heights between level 2 and level 3, meaning where your ultimate lip height is going to be. So the upper marking goes in the subnasal crease. And if you're doing alarplasty or if you're doing lip lifts, it's important to realize that you do not want to go past the natural crease. If you go around the natural crease and over here, it's a sulcus. If you ever cut past the sulcus where there's no sulcus, you're going to end up bridging the areas together. And this is going to cause not only bad pore formation because it's a porous area, but it's going to cause a deep crease that doesn't look very good and you cannot fix. So whether it's with alarplasty or with subnasal lip lifting, never go past the natural crease that exists there. Alarplasty, I could talk to you for hours on how to do alarplasty a few different ways, but you do not want to go past that. The incision you see just stays at the border of the sill and the lip. It goes right across it, and we mark 3 central lines, which is the peak, the central line, and the other peak. And then I draw the diagonal lines, which is the line that I draw by putting my pen in the inside of the sill, just leaning it in there, and then dragging it down in the direction of the pores on the lip, which again, it'll be somewhere between the angle of the P and the angle of the nasolabial fold if you look at how it progresses outwards, in case you ever missed that. Then I look at the excision height, which is going to be partially determined by how much tooth show I want. And tooth show is very difficult to fully control. The only thing you can really control is not doing too much. So you can't really say, I'm going to do 5 millimeters and get 1 millimeter. I'm going to do 7 and get 2. These things are largely variable on the function of the mouth. And sometimes you do a 4 millimeter lip lift and their mouth starts functioning out of nowhere and they get 6 millimeters of increase in tooth show. Sometimes you do a 10 millimeter lip lift and they get 2 millimeters increase in tooth show because they have doughy, thick skin. So it's really difficult to predict. And I've been researching this for over 1,500 patients now, and I have no conclusion as to what is the actual change that you'll get. But to help guide people, I say, in general, it's like ptosis repair. So if you look at ptosis repair of the eye with a conjunctival muleirectomy, if you do 7 millimeters, you get about 2 millimeters change. And it'll get you into the right zone, so you'll never overdo somebody. And that's really the purpose of understanding those, is that you can do a 4 millimeter lip lift without really changing most people's tooth show. And you don't want to go over 11. If you go over 11, there's no way you'll ever be able to redistribute that skin properly. So 11 is like a huge lip lift. You can't go over 11 millimeters of excision. As far as the proper lip height, there is no proper lip height. So there are several articles that focus on what the proper lip height would be. And these were most likely written by morons who don't understand anything about plastic surgery and don't understand anything about what a face should look like, because there's no measurement that would tell you what a lip height should be. It can be anything that matches the face. In addition to that, you cannot look at a population statistic of saying there was an average of 12 to 14 millimeters or 11 to 14 millimeters in good-looking women that we looked at because we analyzed supermodels, and we're going to take that number that we saw in an average in this study, and we're going to apply that to your face, even though you have nothing to do with those patients' facial structure and you're completely different. So my advice there is don't even read those studies. Those articles are completely wrong. There is no indicator that any of these articles would be right for any reason. So they make no sense. So there is no number on what the lip height should be, whether it's 11 millimeters, 14 millimeters, 17, or 20. It is whatever matches the patient's face and doesn't cause any functional issues. So you're treating the individual patient And you can never use a population average observed amongst supermodels to treat your patient. That is a very poor understanding of facial aesthetic. And this is one of the big problems in plastic surgery. So there's a lesson to be learned. Don't listen, don't read those studies even, or if you read them, just realize you're reading them to learn what not to do. Over here, after we choose the excision height, back to this, we can look at the residual heights. And so we look at the residual height of the central line or the paramedian line. And let's say here we measure it as 12 millimeters. We're going to use this to help design the rest of the lip, to say how much are we going to leave behind on each of these little puppet lines in order to get the shape of lip that we want. And the softest type of appearance I've found is by continuing the slope that you would find on most people in the Cupid's bow outward. So if you look at the Cupid's bow, there's a peak and a trough and a peak. And most people would have a 1 to 2 millimeter dip there, around 2 millimeters, let's assume for ease of understanding. And if you look up at the columella also has about a 2 millimeter dip. So it parallels the columella. Cupid's bow parallels the columella. Now, if we have a 2 millimeter dip here and we come up 2 millimeters, then now we can follow down 2 millimeters, 2 millimeters, 2 millimeters in the same spacing. And this helps you design the lip, because you'll say, okay, well, the central lines already have a 2 millimeter dip naturally from the columella. So I'll keep the C and the P line the same. That's 12 millimeters on this patient. And I'll add 2 millimeters and get to the next line, 14. Add 2 millimeters, get to the next one, 16. So now you have your CPID, which the P, the I, and the D have a 2 millimeter slope difference in between each of them. If you cut the lines in half and you put 2 more lines, then it's a 1 millimeter slope, because then it goes 12, 13, 14, 15, 16. And it's nice to do that when you have a lip that's kind of hard to understand, or it looks broad or flat. It just helps you draw it out better. But it's the same calculation, which is a 2 millimeter slope. Outside, we look at now, that's for the subnasal lip. So this is for your subnasal lip lift. So now let's look at the subfacial lip. The subfacial lip, you have to imagine that that level 2 line, which is that horizontal line that I drew over here on the patient, is going to end up at the plane of level 1, which is going to be at the base of the nose. And when we look at that, we say, okay, just like the brow, we want to keep the brow height the same as it goes all the way across, and same with the lip height. So all you do is continue the same slope of 16 millimeters, draw the other one 16 millimeters down, and you can determine the height of your corner lip lift. So the way you determine the height of the corner lip lift is you can draw the diagonal lines, you draw a horizontal plane, and the height of your diagonal line should be the same exact height as the outer line, which determines the height of your corner lift. Now, there are 2 types of corner lifts that I do, or 3 types now. One is a type 1, which is very rarely indicated, and that would be for somebody who's just missing a little bit of lateral lip and you want to expose it by advancing the vermilion. However, you don't want to change the position or weight on the commissure. 95+% of people get a type 2, which is a little more natural, I'd say, for what we're trying to do here. And that's just like the upper blepharoplasty that has a little lateral limb extension as it comes around towards the orbital rim. Here you come around and you get rid of that hooding that goes lateral to the commissure. And this helps take the weight off of the commissure, gives it a little bit of an upward angle or neutralizes it, and you can advance the vermilion. So most people get this type 2. In addition, there's a type 2B, which means B is for back cut. We make a back cut on the lower lip to be able to reposition the chelion or the commissure laterally if you want to make it a longer lip, or higher if you really have angular depression. And then you can trim some skin from under it when you do that. And it's a very easy thing to do. But the most natural for most people and the most effective is this type 2. Looking at the differences between a subnasal lip lift and the Cupid lift, you can see my own failure here. So this is a patient preoperatively who has Juvederm. You can see Juvederm is filling the lip. It's white. It makes it discolored. It is the worst filler for the lip, but it's the most commonly used filler for the lip. Another thing for residents to understand is 95% of what you see doesn't look good. And it means that the most commonly performed procedures in cosmetic surgery are typically the wrong procedures performed in cosmetic surgery, which blows your mind when you're in residency. And I'm sorry to tell you that at such a young age, but that's the reality of it, is that most people don't have good taste again. So when you see here, it's the most commonly used filler. It's also the worst filler that you can use. We dissolved it out, did a subnasal lip lift. The subnasal lip lift provided this over here, which on this patient had a little bit of scarring, unfortunately, and the lip looked okay, but not super well balanced. And then she came back to me and said, can we do anything else? And by this point, I had figured out this whole Cupid calculation, and I was able to draw out the improvements that I could make. And this is my revision now. And you can see my classic subnasal lip lift looked decent, not great, didn't scar as well. Now I did a Cupid lift, and you can see how much more exposure you get, how much more delicate it looks, how much less weight there is on the side of the mouth. So a lot of improvements in this patient just from applying that Cupid calculation. This is what a subnasal deep plane lip lift looks like, meaning a subsmass. Again, it's not the true deep plane of the face, but we call it the deep plane. So you just go subsmass over here and elevate the smass off of the perioral musculature, the orbicularis. And this allows you to elevate it over the musculature without causing a problem. And most people don't understand what this layer is. This is what we call the fibrofatty smass layer. Do you mind? It is a fibrofatty fascia layer that we call the smass. It's part of the superficial musculoponeurotic system. However, it's called the smass fascia, we call it, which would be the same as the area over here in the midface that we use to elevate in your deep plane, and it's the same thickness. And if you look at the volume of it, it is about 3-4 millimeters in height, and it's a hydratory layer that provides most of the support to your skin. And this is a very important thing to understand about skin. Skin in itself doesn't do very well. It relies on a support structure. The support structure underneath is your hypodermal fat, which is really, really tiny layer of fat. And then inferior to that or deep to that is going to be your smass layer. So your smass layer in the face is the most important for providing functional support to the upper lip to allow it to look good. And if you ever elevate skin off of this layer, you lose support. If you ever dehydrate this layer, you lose support. If you dissolve this layer and don't refill it sometimes, you can lose support. So if you look over here at the volume, you'll see that the dermis is only about 1 to 2 millimeters thick, and the smass itself is about 4 millimeters thick. Here is a corner lip lift if you want to see what the smass looks like as you get toward the muscle looks like as you get towards the vermilion border. When you get towards the vermilion border over here, you can see that this is your pars peripheralis, which is in the philtrum, and then this is your pars marginalis, which is actually in the submucosal layer, lamina propria. It's connected into the lamina propria, which is your contiguation or continuation of the smass layer, which is different here because it doesn't have any fat elements in it anymore. North of the vermilion border, there's fat in the smass. Inferior to the vermilion border and the dry vermilion, there's no fat in the smass at all. It doesn't naturally exist there, which is why it's not a natural thing to graft fat into the lips. It can change the color of the lip. It can cause lumps and bumps. And if you inject fat where fat doesn't exist, it never fully integrates. So it's more common to cause lumps and bumps. So it doesn't mean don't graft fat. Just realize you're grafting it where it doesn't want to be. So if you ever do that, you have to just do it judiciously, meaning you put very, very small amounts and you won't cause problems that way. And I have tons of surgeons who tell me I graft the lips all the time. It looks great, but I look at their results and they disgust me. They're not very good looking. So I do fat grafting in the lip. I do very little amounts and I don't cause problems. It's always better to be conservative if you're putting fat where fat naturally does not belong, because it will never integrate in there. The good thing about that is if you ever want to remove a fat graft from an area where it doesn't belong, it's very easy to do because it never integrated. You just pop it open, pull it out. It comes out really, really easily. You see this when you're trying to remove fat from the suborbicularis, when someone grafted too superficially under the eye. You see it in areas of the temple as well. So these are just design elements just to show you on different lips how we apply the Cupid lip equation, and you can get a nice balanced result where the lip doesn't look exaggerated. It looks nice and you have exposure all the way to the sides, and it looks like nothing was ever done to this patient. And that's really the proper way to do this. And if you could see over here, she's got nice exposure on the sides of the corners and everything. These are examples of how I use it in revisions. And if you look at that patient that I showed you where I had a failure and then I fixed it later, this is her. This was my lip lift that I had done previously. And I did a classic subnasal lip lift, 5 millimeters all the way across. And if you see when you apply the equation, I should have done a laterally biased lip lift. So I went back and remade the entire incision and took more from the lateral portions than the central portion. It helped me with other revisions as well for the same reason on this guy over here and on these two patients over here for asymmetries. And you can make someone's lip more symmetric with this. You can really never make someone's lip fully symmetric, and you don't need to, but it does help with symmetry. And also, as a style point, please understand that symmetry is not beauty. Symmetry is not beauty at all. There are certain parts of asymmetry that cause disharmony in the face, and that's a whole nother concept. But having a fully symmetric face does not make you good looking. Here you can see another example, getting exposure all the way across. And these are all listed in the article, so you can just see how these, examples of these designs in the article, if you look at it. And you can see how a mouth goes from depressed to neutral. So you don't want to make it look like it's going upwards, but you certainly don't want it to be pulling downwards and looking sad. And you can see how the coloration in this patient over here, that's Juvederm. Get rid of it. And if you can look down over there, the lips are brighter. That's not lipstick. This is from getting rid of the white gel that was underneath there and allowing the light to now reflect through her lamina propria a little more naturally without having so much gel in it. And you can see the reflection of light going through the lip, coming back to your eye. And the color of the lip is formed by a few things, one of them being blood supply, the other being the pars marginalis, which is those muscle fibers that are actually enveloped in your, or intertwined in your lamina propria. And if you don't have a thick enough layer there, then it reflects down to your pars peripheralis, and then you end up seeing the burgundy of the lips. So you get darker lips. If you have too much space, then you just don't see any blood supply or anything, and you just get white like this. This again is another lip that got darker over time from dissolving, and you can, well, she has lipstick, so you can't see in the after, but either way, her lip did get brighter. And then this is our new lip center called Cupid Lips, which one day I will be opening one in Ciudad de Mexico and Monterrey as well. So that's the entire presentation for you guys. And let's see if you have any questions over there in Mexico. And you can do this in Spanish if you like.
Hey, doctor. Well, thank you very much for this one, Cupid Lift. I don't know if anyone at the participants have any questions about it, or here anyone has questions for Dr. Tully? No. Well, maybe there's like awesome for this one. Are you gonna talk about the deep plane or the R lift, or
I think
talk about...
We'll save that for when I come there, so I can give you a lecture in person, and then we do the surgery.
Okay, perfect. That would be awesome for it. So as there's one of the residents here that he wanna ask you something.
Hi, doctor. Nice to meet you. I have a question. There's another technique where you do the incision in the upper lip vermilion. I don't know if you have any experience to do the incision not in the base of the nose, even if in the lip. Some European surgeons do it there.
Yeah. So Europe is improving slowly. Will. You don't touch the vermilion border unless you have to reconstruct a deformity. So if you have cancer that you have to fix, or you have a cleft, or you have other issues where you have a deformity or anything like that, you don't want to touch the natural vermilion border. The vermilion border itself has this white roll to it, and it's not a real border, but it looks like a real border. And when you touch that border, you get bleeding of the color there. So it's not a sharp delineation anymore. And have you seen somebody with herpes on their mouth, or they get those sores? The whole lip border kind of looks like that. It has this little rough texture to it, and you have to send them for lip tattooing afterwards. So I would say if you're not reconstructing a lip, don't do that. There are certain situations where people have no lip at all, and you have no other choice but to do that. Then yes, that's a good option to know about. But it's very hard to design it to be perfect. So it is a good option to learn about. It's a good option to know about. And it's good for somebody who has zero lip at all. But in my entire practice, I've gotten away with doing other things that are a little more preservational, where we don't distort the anatomy. So I would advise learn about it, but really preserve use of it for defects and cancer and really, really extremely difficult patients. And then afterwards, you have to send them to do tattooing on the lip border in order to restore a smooth kind of look for it to it. On the corner lift over here, it's not an issue because the vermilion roll disappears, and you can actually cut on that lateral part, lateral to that diagonal line, without causing effacement of that or bleeding of the appearance on patients.
Okay, and another question. There are some facial surgeons that cut the orbicularis oris muscles and then do a muscle roll to give some volume of the upper lip. I don't know if you do something with the muscle or you just stay under the mask.
I don't like to touch muscles on the face because I can't control them. And because I can't control them, if I'm the only way I'll alter a muscle on the face, unless there's something wrong with it, is just by using Botox. And Botox for lifting the lip, Botox for a corrugator, or Botox for anything. In general, it is not a good idea to try to alter with mimetic muscle function. Now, the orbicularis is probably the most simplistic of the middle part of the orbicularis is the most simplistic part of these muscles, but there's with the pars marginalis, which actually controls pursing and kissing and those kind of things, not a good idea to touch it. And also, you have to realize that these rolls occur because of the junction of cleavage planes and things like that occur in embryologic development. You can't recreate those. So even though we can imagine that we can recreate a philtral column or we can recreate a vermilion roll, you can't really do that. So the only situation, which again, you have to know about these procedures because you might have to use them for something. I don't use them for cosmetic surgery. You would use it for reconstructive surgery. So for a patient who, again, had a cancer defect and you did an Abbey flap, or you did a transposition flap, or you did an advancement of the border and they lost their entire border, yes, you can do these things on those patients. So these are reconstructive techniques, which should not in general be used on a cosmetic patient. So they're two different things. And going through residency, you have to determine, which one you're treating, because you're going to be a plastic surgeon who does cosmetics and a plastic surgeon who does reconstruction. So you have to know about all these techniques, but I don't like to alter people's anatomy unless they have a big problem and the anatomy is already altered. You understand? So if they're already looking, don't change those things. But if they have a cancer defect, yes, you need to know how to do that. And you can try to recreate some of these roles. And that's where a really good reconstructive surgeon brings in some cosmetic application.
Okay, thank you very much.
Well, Dr. Tala, there's another one. People that are asking something about it. And there's another question about regarding vermilion preservation. How about of doing a corner lift? Do you need to make an incision in a white roll outside of it? There's
so
from Zach.
So a corner lift is meant to, well, there's part of this too, Zach. The corner lift is meant to advance the vermilion. And because it's meant to advance the vermilion, you want to cut just at the junction of the red vermilion and then excise the skin that's above that. There is no white roll on the corner. If you look at everybody's lip, again, lateral to the diagonal line. So what you're doing is you're cutting away the philtral skin of the philtrum, and you're just advancing the vermilion. If you cut on this side of the red, you've ended up getting rid of what you want to advance anyways. And if you cut on the other side of the white, then you end up having a scar that's above the border instead of just at the junction. So it goes, you just draw that lower limb of your incision directly on the junction of the red to the white lip.
Okay, perfect. Thank you. There's another question about how do you treat about when you do the corner lift in the second one stage, how do you treat the scar that goes to the white vermilion under the mouth here? How do you treat it? Because there's some, it's like something spirit about it, but I never treated, and I thought the scars will be like upper, but in sometimes the scars will be downed. And how do you treat that doing the corner lift?
So on the corner lip lift, the first thing to realize again is that the color of the red of the vermilion comes from the vascularity of it, blood flow and reflection through the lamina propria and muscle fibers. And this is altered in the first 3 months. So in the first 3 months, it may also, this is a whole separate thing, but it may look like the incision is on the white side of the lip, but it's really just the vermilion doesn't have color in it temporarily. And then it comes back as the blood flow normalizes and the skin isn't congested and thick anymore. If you form a scar here, it is typically thickened, and it can be thickened as a white thickening, which is the most common, or you can have true hypertrophy, which is really rare. So you don't really get the hypertrophic scarring that you would see that has actually blood flow in it and things like that. It's just usually a white scar that forms there. Typically, I inject that with 5-fluorouracil. 5-fluorouracil is much safer as an immune modulator rather than using Kenalog or triamcinolone, because it won't cause color changes and atrophy. It'll just soften it, and then you laser it with a CO2 laser twice, and it's gone. So in most cases, that's fine. Now, if you did a bad corner lift with tension, you have to cut it out. And then this is a big problem because it'll advance the lip more and the side of your mouth starts to look kind of sloppy. So it's very difficult to fix it typically once somebody's already done like a big corner lift there without releasing it. However, if it's yours and you do it the way I do it, then it's very easy to fix because it just gets a little thickened. You soften it with 5-FU, you laser it, and I've never had to do anything more than that.
Okay, perfect. Well, I think there's anyone has another question. Well, thank you very much, Dr. Tully, for this amazing lecture about Cupid Lift. I think the other one will be awesome. We will see you here in Mexico City at December 15th at the General Hospital. There's another one. How frequently did you laser of 5-FU?
Yeah, or the corner lift. So, yeah, so I use 5-FU only as needed. It's pretty infrequent. But as far as timing goes, every patient I do a lip lift on comes back to the office at 6 weeks, and we do a CO2 laser across the incision and on the corners or wherever the incisions were. And it doesn't matter their skin type, because CO2 lasering is just risky when you're doing skin resurfacing. It's not risky to laser an incision. So you could be any skin type and you can laser that incision. Then we repeat that at 12 weeks or 3 months. And on about 80 to 90% of people, that's all that's ever needed. Even they don't even need that. But 10-20% of that range, I haven't determined the percentage, but it's around there, that they actually do need more lasers, and we'll do it twice more, 5 times more, whatever is really needed. And it's typically done every 6 weeks. The 5-FU, you can repeat once a week if you wanted to. It's safe to do. Whereas Kenalog or triamcinolone, you really want to limit it like once a month.
Okay, well, perfect. Okay, Dr. Tully, well, I think that's it. Thank you again for it. And we will see you here in Mexico.
En diciembre.
En diciembre, 15 de diciembre, aquí nos vemos en el Hospital General de México. Well, so everyone here, say you goodbye. Thank you for this amazing lecture.
Pleasure, my pleasure.
Okay,
all right, enjoy the rest of residency.